Mr. Chairman, dear colleagues, I would like to thank especially my big friend Greg for the kind invitation. So, okay. One time there was the task 2 classification with the recommendation to treat task C and D lesion with surgery. And more than 10 years ago, I published my experience on aorto bifemoral graft for the occlusive disease of the aorta and iliac arteries with a very good result, especially mid and longer term results. And this operation actually is performed only in selective cases because you know that presents some disadvantage, especially in obese patient, problems related with the laparotomy itself or with the operation, including a lesion to the structure close to the iliac arteries and the risk of infection. And in the last 20 years, a lot of big experience with the endovascular treatment of iliac arteries occlusion showed a good result of this endovascular procedure. And I want to underline this famous trial, the Bravissimo trial. I had the honor to participate to this trial, and this trial, a randomized trial, demonstrate very good result of endovascular treatment for iliac artery disease, even in task C and task D lesion at 2 and 3 years. So in the real world, these lesions are treated with the endovascular first approach. We have several possibilities to treat an iliac occlusion. We can use a contralateral approach. This is a case with a stenosis of the right common iliac arteries and a complete occlusion of the left common iliac artery. With a contralateral approach using dedicated catheters, I prefer to use a straight tip hydrophilic guide wire. It is possible to recanalize the common iliac occlusion. After this, the procedure is the same procedure we use commonly for bilateral iliac disease treatment with kissing stenting and balloon stenting. But we can use in other case an ipsilateral approach, a retrograde approach to the iliac occlusion. This is an example. You must be a little bit lucky when you want to recanalize with the ipsilateral approach a common iliac occlusion, but it's possible and is justified to try to recanalize this kind of occlusion. This is the result with a very good result, and the check is performed by the contralateral side. But the most used approach is the double approach, contralateral and ipsilateral. This is an example of external, right external iliac occlusion, recanalized with a bilateral, a double approach, contralateral and ipsilateral. Let's go to some tips and tricks for this endovascular treatment of chronic iliac occlusion. In my experience, I prefer to avoid to obtain the re-entry in the aorta. aorta. So I prefer to stay intraluminal using O14 guide wires for chronic total occlusion. This is an example, a Victory straight tip, 25 grams, in order to avoid a wide subintimal space, especially in the aorta, in order to stay as possible intraluminal, and to obtain the recanalization even in calcified chronic occlusion. If the retrograde approach, ipsilateral, is not successful, we can try the antegrade or the double approach. This is an example. To obtain the recanalization by a contralateral approach, is mandatory to have a dedicated catheter for the contralateral approach. The UF is an example, but my suggestion is to use a modified pigtail. The pigtail is always available, and we can cut the tip in order to the morphology of the aortic bifurcation. In order to obtain the right shape, to recanalize in an antegrade way the iliac occlusion. In this case, when I use the modified pigtail, I can use a more supportive O35 Terumo guide wire with the straight tip, and with these tricks we can recanalize even calcified arteries. Is mandatory in occlusion, in chronic occlusion of the iliac arteries, to avoid to lose the true lumen. So when we obtain a contralateral recanalization, we have several possibilities. We can use a snare kit, or it's possible to use the guiding cut technique or the catheter in sheet technique. In this way, it's possible to preserve the true lumen, the guide wire in the true lumen, and we can perform a predilatation of the occlusion and obtaining a lumen for the aorta in the side we want to treat. The last suggestion is to pay attention to the external iliac artery occlusion. The external iliac artery occlusion, the external iliac artery is a fragile artery compared to the common one. And when we treat a chronic occlusion of the external iliac artery, we must avoid an overdilatation. It's better an underdilatation of the iliac artery to avoid the rupture of the artery stent. The covered stent in this approach, in the treatment of external iliac arteries, must be always available, but in this case you can see inside the stent, the covered stent. In this way, is better to have a vascular surgeon always available, because we convert this kind of case. So in conclusion, Mr. Chairman, dear colleagues, the endovascular first approach for type C and D lesion is feasible and safe, with high patency rate at longer term. Surgery is recommended, in my experience, only for endovascular failure. We need dedicated materials, guide wire for CTO, dedicated catheter, and long sheet when we want to approach in an antegrade way from the transbrachial or transradial axis. And please pay attention to the external iliac artery occlusion. Thank you for your attention.